Hugh McGregor, who is going to speak to us on robotic TAPP, technical tips and pearls. He's a general laparoscopic and robotic surgeon, senior consultant surgeon, Redcliffe Hospital, North Brisbane, Australia, as well as North Lake Specialist Medical Centre. Hugh.
Good afternoon, ladies and gentlemen. Thank you for giving me the opportunity to have a chat about things I've learnt, tips and pearls in regards to robotic TAPP inguinal hernia repair. My robotic journey, I'm a general surgeon in Brisbane. I'm in mixed public and private practice, and about 50% or more of my work is hernia surgery. In 2019, I commenced robotic surgery. Device Technology, who services the Da Vinci device in Australia, has an excellent training program, and I undertook that. Firstly, built-in exercises on the robot, which with stage progression, and then there's an excellent pig training centre in Sydney at RPA. You go down there for the day and take your assistant. It costs a few $1,000s, but is an excellent training opportunity. Intuitive then provided a mentor to supervise some cases, and I took it from there. I now have access to 3 robots in Brisbane, and I primarily use it for complex and redo inguinal hernia repair, mesh removal for pain, ventral incisional hernia repairs, and for hernia repair in very high BMI patients. rTAPP was actually the most common general surgery procedure performed in the United States in 2019. Trainees in the US are often only learning robotic surgery, and it is certainly becoming more common. However, I particularly find it useful for hernia repair post-prostatectomy, whether that be open, laparoscopic or robotically. As we all know, minimally invasive inguinal hernia repair after prostatectomy can be very easy or incredibly difficult, probably depending on whether the patient had a post-operative urine leak. I use it for very high BMI patients having primary inguinal hernia repair. I see quite a few patients with mechanical chronic pain, and I use that for mesh removal. Certainly, it makes redo laparoscopic repair much easier. And also, I think it's an excellent technique for general familiarisation with robotic surgery. I will admit that I was a skeptic and have had multiple debates with colleagues in the US. However, it is an excellent operation to become familiar with the robot and to refine technique, to then enable surgeons to undertake much more complex repair. TAPP inguinal hernia repair is obviously a very familiar operation for many surgeons, and it's a good opportunity to get the cobwebs out and to really become very comfortable on the robot. When we talk about rTAPP, there are technical factors, and these include patient positioning and anaesthetic considerations. We generally have the patient with their arms in, and it's important that the patient be intubated with an endotracheal tube. As you can see from the photo, there's significant head-down posturing during the operation. I'll talk about port placement in a second. Connecting the device to the patient is a systematic technique that takes several minutes, and after it's, while it's initially a bit daunting, after it's practiced, it becomes second nature and very fast. I'm going to talk about instrument and mesh choices today, and also time management. Time management is very important because these operations take much longer than you are used to, and they take much longer than you imagine, especially at the start. The timings come down, they get very refined very quickly. However, it's very important that you allow yourself time because you do not want to be doing these cases under time pressure. So port placement, often we use 8mm ports. There are 12mm ports, but they're unnecessary. 8mm ports, and the ports come with optical entry systems. I often use a Verres needle to inflate the abdomen and then use direct entry. However, you can use a superior umbilical Hassan's technique to place the port. It's important that your camera port is above the umbilicus. The other two ports, it's unnecessary to use the fourth arm, generally 6 to 8 centimetres lateral to the umbilical port. It's important not to place them too lateral, and it's also important not to place them too high, as it becomes very difficult to reach the patient. Instrument choices. Instruments are very expensive. They cost $500 each, and it's important to make the correct choices. There are approximately 30 choices of instruments. I find that the fenestrated bipolar grasper, scissors, and a needle driver, either with or without scissors, is all that is necessary to facilitate the operation. I've always used laparoscopic pro grips since it came out. I have an example here of just cutting that, and I popped this up because this is a technique that I learned from my colleague and good friend in Indianapolis, Paul Sotek, and it just makes placing the needle and the mesh very simple. It reduces the risk of losing the needle, and as you'll see, it makes application much easier. The technique of rTAPP is exactly the same as a laparoscopic tap. There is very little difference. However, you can see my mesh application here and pre-packaged needle. In this setting, I use a 15 centimetre 3O V-lock, and it just makes it very simple. I place the mesh in at the start of the case before I've even dissected out the groin. So the actual technique of rTAPP is exactly the same as TAPP, with the exceptions of those technical factors. Where the rTAPP comes in and the robot comes in is very difficult things like redo repairs, mesh removal for pain, etc. In this scenario, this is sped up. I'm taking down a previous mesh repair, which has failed, and there's a recurrence. When you're doing this, it's important to note that we often think about the peritoneum and the abdominal wall as being the only components in the groin, but of course there's another layer of fascia. And it's important to use that layer of fascia to facilitate your mesh removal, because often the mesh is just under the peritoneum. Often the mesh is actually deep to the fascia, and we can utilise that added space to make the mesh removal easier. Again, in this video, just representing the fact that the mesh, the old mesh doesn't get removed, it gets taken down the peritoneal flap. And again, the hernia is repaired in exactly the same manner as a primary hernia repair, ensuring that it's done properly and minimising the risk of recurrence. So benefits and pitfalls. The benefits of rTAPP and of the robot generally is that it does allow you to do impossible things, things that would be impossible with other minimally invasive techniques. It also allows you to do very difficult things with much more precision and minimal tissue damage. It's also an excellent training and familiarisation procedure to use the robot. And you also get to take pictures of yourself wearing colourful socks, which you can post on Facebook. The pitfalls is the cost. Hopefully the techniques of instrument choice, etc., brings that cost down, and the cost generally will come down over time. In fact, the most expensive robot is the one sitting in the corner not doing anything. So I think hospital systems are much more comfortable allowing us to use the robot for these things. Pitfall of the robot is a difficult operation, is still difficult, and a bad operation is still bad even if it's done robotically. It's not a magic instrument. It's just a tool to enable a good surgeon to do difficult things. It does take a lot more time, especially initially, but those timings come down with experience. And it's not magic. It is a tool. You do get worn out. Different parts of your body hurt. It's a very good workout for your thenar muscles. As I stated before, a bad operation is a bad operation, whether it's done laparoscopically, open or robotically. Thank you.
Thank you very much, Hugh. Very nice talk. Again, just in the interest of time, I won't take too many questions, but I just wanted to find out the situation in Australia. Are you funded to do these just for complex reuse, or is it something which you can get funding for routine hernia repair? That'll be quite.
It's actually getting easy. Yeah, it's actually getting easier and easier to convince hospitals to do it. And initially, it was quite difficult, and they had to be either Veterans Affairs or specific health funds. But these days, the hospitals don't complain much because, as I said, the most expensive robot is the one sitting in the corner not being used. So they're happy to do it. They know that we're making a big effort to minimise cost, and by only selectively using instruments. And of course, as we progress on, we get faster. So there's the time and the benefit of doing those things is faster, and it's also a marketing tool for hospitals to say that, you know, they can offer these services, and so along those lines, they're happy to absorb the cost.
Yep. Thank you very much, Hugh.